I'm going to start recording and then share screen. I don't have to do screen sharing very often, so I apologize if this is not my. Yeah, so that's kind of how it will look. Okay. And then I will just sit over here, and then if anything perfect wonky comes up, it should be. Do you want the volume on at all? I mean,
No.
Is it? No. Okay, you're good.
Hi, I'm Dr. Wood. I'm a pediatric endocrinologist here in Billings, Montana, and I trained in my endocrinology at Denver Children's Hospital and the Barbara Davis Center, which has a large cystic fibrosis population. And so I got some extra training in cystic fibrosis-related diabetes before I came up here to Montana on the request of our pulmonologist so that our patients would be able to be cared for adequately. So I'm super happy to be able to talk to you about CFRD. This information is largely taken from Dr. Tony Moran, who's probably the leading physician in cystic fibrosis-related diabetes. And most of this is coming from her research, which is a little bit more progressive than what the Cystic Fibrosis Foundation has published to date. Her research is what's driving the recommendations in the treatment of cystic fibrosis-related diabetes. And the changes that you see in the next 5 years in your management will probably come from her research as well. So when I'm talking, if some of this seems kind of new to you, it's maybe because it's not published and it hasn't reached your local physicians yet. So my goal is to give you some of the most up-to-date information on CFRD. And then at the end, I'll take questions. I'm not as computer savvy as Kat is, so I'm just going to let her help me field the questions at the very end. If you can't see me, wave your hands around or something so I can so I can tell that you can't see or hear me, and I'll try to make her fix it. So I don't have any disclosures to make. I'm not paid by anybody to tell you this information. She's not even paying me.
So lame.
I told her she didn't have to. So you don't have to worry that I'm biased by anything. So our main objectives today are that you understand how we're diagnosing cystic fibrosis-related diabetes and how that diagnosis is changing your prognosis and how you can alter that with a proper treatment, and then also know the possible future directions that your treatment might take, and also how some technologies might help you with your treatment. So cystic fibrosis-related diabetes, which most of the time I will call CFRD because it's a mouthful, is the most common comorbidity in cystic fibrosis. And what that means is that it's the most common disease that coexists with cystic fibrosis. And it's actually caused by your cystic fibrosis, but it's actually a separate disease state as well. And basically what it is it's a state of insulin deficiency. And so what that pretty much means is that in a normally working pancreas, what's supposed to happen is that you eat food, it gets absorbed into your guts, and then up into your blood with your enzymes. And those enzymes should be coming from your pancreas, but in most people with cystic fibrosis, you have to take enzymes to help absorb your food. And then once it gets into the bloodstream, your insulin, which also comes from the pancreas, takes that food in your bloodstream and it puts it into your cells for energy. So it puts it into your brain, it puts it into your heart, it puts it into your muscles. And if you do not have insulin, the sugar gets into your blood, but it's basically unusable. So in cystic fibrosis-related diabetes, you have an insulin deficiency state. And that comes from the fact that the enzymes that you're supposed to be making and squirting out into your guts to absorb your food is basically not getting adequately squirted into your gut, and instead it's just sitting on top of your pancreas, and those enzymes are chewing up your own pancreas. And so the piece of the pancreas that makes insulin is getting chewed up and killed. And so as you live longer and longer, less and less and less of your pancreas is working. And so you're making less and less insulin. This is a problem because not only can you not use your food for energy, but you actually then lose weight. And weight loss is a huge problem in people with cystic fibrosis and is strongly correlated with poor outcomes. So you need to be able to use your food for energy in order to keep your weight on. Insulin itself is also a growth hormone. And so in the absence of insulin, you just don't grow as well, period. You don't have as much muscle mass or fat mass, and your overall strength and well-being can decrease just from the lack of insulin. Also, if you don't have enough insulin to take the sugar out of your blood and put it into your cells, your blood sugar will rise into the abnormal range. And once it's higher than 140, that blood sugar can diffuse into the lungs, and it can make the mucus in your lungs thicker, so it can be harder to expel, and it decreases your pulmonary functions. And it also makes it a better home for bacteria to grow in your lungs because there's a bigger sugar source there. So people with untreated cystic fibrosis-related diabetes have more infections, more severe infections, and infections with worse bugs. What we know, though, is if you can identify CFRD early and treat it early, outcomes improve greatly, and that doesn't have to happen. So this slide basically shows how CFRD can affect you. So you can see the CFTR gene mutation is what's causing your CF. And then from that, you can have infections, malnutrition, chronic inflammation, and you might need steroids. And that's just from your CF. All of those things there lead to the fact that the insulin that you do make doesn't work as well, and you actually need more insulin. In addition, having CF makes you have thick mucus, blocking the pancreatic duct, and then you get fibrosis, which is that scarring of your pancreas. And then you also, just by nature of having CF, have a higher genetic susceptibility to getting diabetes, and you have less insulin production. So the insulin you make does not work as well, and you make less overall, and then your blood sugars go high. So why is this a problem? Especially early on, people wonder why this is a problem, because a lot of people with cystic fibrosis are diagnosed with CFRD or kind of the pre-stages of CFRD and are recommended that they go on insulin before they're feeling any different, before they notice anything bad is happening. And sometimes they don't even detect it in their blood sugars. And the reason for that is that in a normally working pancreas, what happens is that the second you eat food or drink soda or have sugar in your belly, you give a big spike of insulin. And that big spike of insulin is called a first phase insulin. And that prevents your blood sugar from spiking up in the first place. And so your blood sugar stays stable even though you're eating. Take a second phase of insulin that helps process the food that you eat over time. So if you eat a big steak dinner with bread and corn, then you get that first spike to handle the initial things that hit your tummy, and then the second phase that handles that slow processing of the rest of the calories. In cystic fibrosis, you lose that first phase insulin. And so what happens is that you can see here that in a person with cystic fibrosis related diabetes who does not have the first phase of insulin, their blood sugar spikes way up high right after they eat, and it peaks up at about 60 to 90 minutes after they eat. And then in the absence of a second phase of insulin, it doesn't come down very well. People who are diagnosed with diabetes or prediabetes look more like this, where their blood sugar spikes up and then it comes back down by that next meal. So if you check your blood sugars before you eat at every meal, you'll miss that your blood sugar is spiking up high right after you eat because you're missing that first phase of insulin. And all of that sugar that spikes up is diffusing into your lungs, which is bad. So when we're talking about cystic fibrosis related diabetes, this is something that is developing slowly over time as your pancreas is getting degraded by your enzymes. So at first what happens is that your blood sugar just spikes up here and there after you eat. And then you might see some changes on your oral glucose tolerance test, which is that sugary drink that you have to drink once a year. And that's called impaired glucose tolerance. And then you might have diabetes where still, first thing in the morning after you haven't eaten all night, your blood sugar's okay, but then during the rest of the day, it runs kind of high. And then you have kind of what I think of as full-blown diabetes, where you need multiple shots a day. So because this is a slow onset type of disease and has different stages, we have to think about it a little bit differently than other types of diabetes. The other reason why we have to think about it differently than other types of diabetes, and maybe even treat it more aggressively, is because we're treating the different outcomes. So the whole reason that we treat, say, type 1 and type 2 diabetes, which are the types of diabetes that people get, type 1 diabetes is an autoimmune disease where children are completely insulin deficient and they're insulin dependent their whole life. And type 2 diabetes is the kind of diabetes that you might get when you're older or perhaps a little bit more overweight because your insulin isn't working as well. The reason why we treat those two types of diabetes the way we do is because the problems that people have with those diabetes types comes from blood sugar spiking up over 200 and doing damage to their body organs like their kidneys and their eyes and their heart. And this happens from long-standing high blood sugars. So they get what's called microvascular and macrovascular complications, basically heart disease, kidney disease, eye disease, nerve disease, and those types of things. But in CFRD, people generally do not suffer from micro and macrovascular complications. Instead, they suffer from complications of their cystic fibrosis. And that happens when blood sugars go above 140, not above 200. So really, we should be treating CFRD much more aggressively than we treat other types of diabetes, because our goal is not to prevent kidney and eye disease. That's already not happening for the most part in people with cystic fibrosis. Instead, what we want to do is preserve your lung function and preserve your lifespan. This is a much bigger problem than we had initially thought. So many of you guys are adults, maybe all of them. Yeah. And when you were diagnosed with cystic fibrosis when you were children, CFRD was not something we even thought about. If people got CFRD in your generation, when you were teens, many endocrinologists just blew it off. Sort of like, who cares? You've got enough on your plate. Deal with your CF. You're not symptomatic. You don't have to worry about your high blood sugars. And then what happened is Toni Moran started doing her studies, and she found out that people who had cystic fibrosis with diabetes had 6 times higher mortality, meaning they died 6 times more frequently and younger than people who did not have the diabetes. And then she found out that if she gave them insulin, that changed, that reversed. And so once she discovered that, which really it took her until, right around 2000 to discover that, and really it took her until 2010 maybe to get the word out to endocrinologists in general. Once we found out that it made a big deal to treat cystic fibrosis related diabetes, really only in the past 10 years have we been really aggressive about treating it. And her research is about 30 years ahead of about where everybody else is in the country. And she's treating it far before people are even diagnosed with CFRD, so that people aren't even getting the blood sugar excursions or high blood sugars after they eat. That happens before the official diagnosis is made. Official diagnosis is still made based on your oral glucose tolerance test. And when we look at oral glucose tolerance tests, we know that almost 10% of kids less than 10 already have CFRD. 25% of people by the time they're 20 have it. By the age of 30, half of people with cystic fibrosis have it. And that is, that's data based on pretty poor screening. I'll actually show you a slide a little later on. But we didn't do a very good job screening people until just recently. My suspicion is that probably closer to 75% of 30-year-olds with cystic fibrosis actually have cystic fibrosis-related diabetes. This is a silent disease. You're not going to notice symptoms most of the time until it's relatively far into it. But the symptoms are that you'll drink a lot and pee a lot from higher blood sugars. You might find you have a harder time gaining weight or maintaining your weight. If you're a child, you might not grow tall as well, or you might not go through puberty on time. There might be an unexplained decline in pulmonary function or an increase in infections, where you think to yourself, well, gosh, I haven't been hospitalized in 10 years. Why have I been hospitalized 3 times in the past 3 years? It may be partly because of your blood sugars. Occasionally, you can get something called diabetic ketoacidosis, which is actually diabetic coma. That's very rare and really only occurs in more severe types of CFRD, sort of where you're needing multiple shots a day. But in those people, they're so insulin deficient that if they don't get insulin, they actually can go into a coma. And probably one of the most common things that I see early on in CFRD is that they get something called reactive hypoglycemia, which means what happens is they actually have a low blood sugar about 1 or 2 hours after they eat, or 3 hours after they eat, especially if they eat high carb meals. And the reason for that is because since you don't have the first phase of insulin secretion, and you don't grab up all that sugar right when you eat, your body compensates by making a strong second phase insulin secretion. And again, that insulin is in your body for a couple of hours. And it basically, what happens is your body overdoes it and makes too much insulin in that second phase. And then your blood sugar dips after you eat a meal 2 or 3 hours later. That can actually be prevented with a shot of insulin before you eat high carb meals. Right now, how we're screening for CFRD is we're doing yearly oral glucose tolerance tests starting at age 10 or with symptoms. What that means is that once a year, starting at age 10, you're supposed to drink that orange juice. And then they see if your blood sugars go abnormal. And that's really important. Stress to your friends. They should get that every year because people always try to wiggle out of it. But that's sometimes the best way to identify that it's coming so that you can think about it ahead of time and get started on treatment in a timely fashion. Those oral glucose tolerance tests correlate with cystic fibrosis outcomes. What they find is that in the 4 years prior to getting cystic fibrosis related diabetes, people have increased rate of lung function decline. So oftentimes, even before you get CFRD, your lung function is declining. And you can be tipped off by your oral glucose tolerance test that you need to be a little bit more aggressive. You can also help watch for the microvascular complications. And as your generation lives longer and longer and longer with CFRD, I do think that some people will start to get kidney or eye disease if they don't take care of it. And so that helps us keep an eye on your overall body health. And early treatment for CFRD does decrease your overall mortality. This is that slide that I was telling you about that talks about how we screen people for cystic fibrosis related diabetes. And you can see that in 2007, before Dr. Moran's information really came out, we were only screening about 15% of people. In 2012, after her information came out, we hit about 40% of kids and 32% of all comers. And these days at our institution, we're approaching 60 to 80%, with most of the lost ones coming from people just not wanting to get it done. But we're doing a better and better job screening, so I think we're going to start treating earlier and earlier. And I hear that a couple of you guys may have been recently diagnosed or diagnosed with early stages. And so that's probably because of your oral glucose tolerance tests. But we do have a couple of other ways that we can diagnose now. One is your hemoglobin A1C. So if you have a hemoglobin A1C greater than 6.5 twice, or if you have symptoms with that, you have CFRD. A hemoglobin A1C is an average blood sugar over the past 3 months. A 6.5 correlates with about an average blood sugar of 150 or so. So that just kind of gives us an idea of how your blood sugars have been on average the past 3 months. The hard thing with CF is that the A1C is not as accurate of a test in people with cystic fibrosis as it is in other people, because it depends on your blood cells living for about 3 months in order to get an accurate 3-month measurement. But people with CF have their blood cells lasting only about 2 or 2.5 months, so it falsely lowers the A1C. So you may have diabetes and not have an abnormal A1C. We can also do it based on the oral glucose tolerance test, or if you're in the hospital, even if you're on steroids, if you have 2 blood sugars greater than 200 randomly in 48 hours, you have CFRD. Or if you're on continuous G-tube feeds and you have blood sugars over 200 at nighttime on 2 separate nights, you have CFRD. You can also do it in pregnancy, although that applies to less people. In theory, you should be tested positive on 2 different distinct tests to make the official diagnosis of CFRD. But honestly, I don't think that it's that important, because I think that if you're having that much problem with your blood sugar that it even comes back positive on 1 test, you should probably be on insulin in order to start helping your blood sugars and help your nutrition and help your lung function. So it doesn't really change things by waiting for a second test to be positive. That's why we don't make you take 2 oral glucose tolerance tests. Why, when you test positive on 1, we just call it and say you have it. The last thing is well, I don't know how to go backwards.
Sorry, yeah, I know.
The last thing is you can do it by continuous glucose monitoring, and some people will get a device placed on them that basically checks the blood sugar every 5 minutes in the home setting, without you having to be constantly checking your blood sugar. And sometimes that allows us to tell if you're having high blood sugars. That's not an official way to diagnose CFRD at this point. It probably will be in the next 5 years after we get more concrete data about cutoffs. So right now, if you get an oral glucose tolerance test, we say that if you have a fasting blood sugar less than 100 at baseline, that's a good fasting blood sugar. If your fasting blood sugar is greater than 126, you have diabetes. That's an automatic abnormal OGTT. If your fasting blood sugar happens to be between 100 and 125, that's where we might call you impaired fasting glucose, or an abnormal oral glucose tolerance test, but not an official diagnosis yet. The other level that they might take is a 1 and a 2 hour level. And at the 2 hour level, you can make another diagnosis of CFRD if your blood sugar is greater than 200. If it's between 140 and 199, it's impaired. And again, that's sort of the pre-diabetes stage. And if it's less than 140, then you're considered normal. So to be normal, you'd have to have a fasting less than 100 and a 2 hour less than 140. If you test positive, we recommend that you get treated with insulin. And again, insulin is the only treatment that has been shown to improve the mortality rate that comes with cystic fibrosis-related diabetes. No other treatment for CFRD has been shown to reverse the increase in mortality. This data is coming again from Dr. Moran, and what she found in the 1980s is that, this was her initial research, it showed that 25% of her patients with cystic fibrosis who had diabetes survived to age 30 in 1980. But 60% of her non-diabetic group was surviving to age 30, and that was from the excellent pulmonary toilet that was starting to be developed in the 70s, 80s, and 90s. But then she started to do earlier treatment, and this is what happened. So again, in the 80s, people without cystic fibrosis related diabetes, but who had cystic fibrosis, their mortality rate was less. People with diabetes had an increasing mortality rate. This is women, they had the worst mortality rate if they had cystic fibrosis related diabetes. And in fact, she did not have any survivors past age 35 in the 80s. Then in the 90s, she had started treating people probably in the mid 90s with insulin, and her mortality gap decreased. And this was in 2003, which is just shortly after she had started treating. So this is really her first population where she had some people that she was treating early, and the mortality gap decreased even further. Now in her next set of data, which is going to come out the 2009 to 2012 and the 2013 to 2017 data that she'll be publishing hopefully in the next year or so, she had started treating people before they developed CFRD, and that mortality gap is almost completely closed. So that replacement of insulin really is an equalizer for people with cystic fibrosis. in terms of long-term survival. And again, instead of CFRD being a determinant in shortening lifespan, lung function we were able to go back to lung function and keep progressing lifespan through adequate pulmonary toilet. So I'm excited to see her information about that. The next generation is going to have Orkambi added in, and we think that that's actually going to help outcomes as well. So a couple of things that we looked at when we were looking at treatment, and this is me trying to convince you that you should go on insulin if you have CFRD, is that we looked at groups of patients who had cystic fibrosis-related diabetes or impaired glucose tolerance, so almost had CFRD. And all of those patients had loss of their body mass index in the year prior to therapy. And basically what that meant is that their weight went down or that it was unable to be maintained appropriately in the year prior to therapy. And then when they put people on insulin and compared that to nothing and compared that to an oral diabetes agent, the people who were on the insulin had recovery of their body mass index. So their nutrition improved. The people who got insulin also had recovery of their lung functions. So prior to treatment, you can see the lung functions drastically declining. After 3 months on treatment, their lung functions improved. And then over the next 3 years, it took them 3 years to get back to the place that they were on pre-insulin. And it may even take a little bit longer, especially if you start earlier. So insulin therapy is preserving lung function. They did multiple little teeny tiny studies with little groups of people, and they looked at starting insulin of different types, and pretty much universally they saw improvements in lung functions, improvements in BMI, and even if people were started on just one shot a day, they showed improvements. Many people in the early stages of CFRD don't require multiple shots a day. They benefit even from just one shot a day of long-acting insulin. Once it progresses, multiple shots a day are going to be eventually required. So again, insulin right now is the only recommended medical therapy that's shots. It stabilizes lung function and it improves nutritional status. And oral diabetes agents, meaning by mouth agents, are not recommended. We don't have any randomized controlled trials on these agents that show that they help. They don't seem to be as effective in nutritional status, A1C control, which is just general blood sugar control, and lung function. And they're starting to look at a few other types of agents that might be helpful, but nothing has been as good as insulin in all three areas: blood sugar control, body mass index, and pulmonary function. And so really until something else is good on all three fronts, I think insulin's probably the preferred therapy. So some insulins that you might be put on are one, long-acting insulin, that's a shot a day. Those ones are called Glargine or Detamir. Their brand names are Lantus and Levemir. There's some newer formulations available for adults now that are called Toujeo or Tresiba. So long-acting insulin, a shot a day, can sometimes help people kind of get through the day without having a lot of high blood sugars. It basically just brings your blood sugar trend down a notch. You might also be put on what's called intermediate acting insulin. That's for people who are mostly going high just for G-tube feeds. So if you have a G-tube feed overnight, sometimes you'll just need insulin for that G-tube feed and you do fine the rest of the day. You might be put on short-acting insulin, which lasts only a couple of hours. That's really good for people who need additional help for meal times where they really spike up after meals, or people who go low after meal times after high-carb meals. A shot before a high-carb meal might stop that blood sugar crash. And then if you're needing multiple shots a day, then you can go on pump therapy where you don't actually need shots. You just get your insulin administered with a pump through a little cannula that's inserted into your body, and you change that out every 3 days. We'll look at some pictures of that. This is just a visual of how long different insulins last in your body so that you can kind of get an idea of why different ones might be prescribed. Shorter acting ones for meal times, longer acting ones if you just want to lower your blood sugar trends overall. The big thing that you need to know is if you get diabetes, you don't want to change your diet. it does you no good if you eat less calories. People with type 2 diabetes benefit from diet change. People with CFRD do not benefit from diet change. You still need to have your calories, and you still need to have increased protein. You should still have unrestricted salt. You should still have a lot of carbohydrates. You don't really have any restriction on your sugars. You should eat how you eat. The one thing that I do say that you might want to change is if you are a sugar pop drinker or a sugar tea drinker or a Gatorade drinker.
Say this word again.
If you are a sugar pop drinker, Kat said, say it again. Sugar tea, so sweet tea, or sugar like juices, Gatorades, that kind of thing, that will spike your sugar in your blood crazy. And insulin is really difficult. It's really difficult for insulin to handle that load when it's not your own insulin. And it will spike your blood sugars up a ton. And many people who can cut out the Mountain Dew or change it to Diet Mountain Dew are able to avoid insulin therapy because they're no longer having high blood sugars. So that's really the only thing that I would recommend changing if you are cystic fibrosis related diabetes is take your sugar drinks and try to replace them with calorie-free drinks, diet drinks, milk, water, and those types of things. You should not stop Scanda shakes or Ensure or whatever kind of calorie boosting drinks that your doctor has you on, but you might need a shot for those types of drinks. So ideally, if you have CFRD, you would be seen in your multidisciplinary CF center with a trained endocrinologist. Realistically, there are very few endocrinologists specifically trained in cystic fibrosis related diabetes because since it's relatively new knowledge, only relatively younger endocrinologists have been trained in it because previous to 2010 or so, endocrinologists were mostly told, don't worry about it, it's not a big deal. You don't have to be that aggressive with it. It's just type 2 diabetes, so you can give oral agents, all sorts of different things that we have since found to be untrue. So if you can, it's great if you can get an endocrinologist who has some experience in cystic fibrosis related diabetes. If you can't, try to get them to read the latest CFRD guidelines, and those came out in 2010. And that's pretty clear that insulin is the preferred therapy. Your goal is to be seen about your goal is to be seen about every 3 months. So basically when you have your quarterly visit with your pulmonologist, if you have progressed CFRD, checking blood sugars at minimum 3 times a day is great. If you have earlier stages, sometimes you only need to check at a fasting or postprandially, meaning 1 hour after you eat a couple of times a week, just to kind of get an idea of where you're at. And then if you have progressed CFRD where you need multiple shots a day, you need to be checking breakfast, lunch, dinner, bedtime every single day. Your goal is to keep your A1C less than 7, so that's a average blood sugar of less than about 165, to decrease your risk of microvascular complications like other diabetics. So that's, again, it's kidney disease, eye disease, nerve disease. You need to monitor your blood pressures and make sure blood pressures are well controlled so that it doesn't put extra stress on your kidneys. And you should start getting yearly eye exams and kidney tests with a urine 5 years after you're diagnosed. Your goal blood sugars are, you can think of it as like 70 to 140 is a good goal blood sugar. These are from the recommendations from 2010, and I think they're going to make these a little bit stiffer than they are right now in the next set. But I usually say if you can wake up fasting 70 to 100, that's awesome. And then if you have a pre-meal blood sugar less than 140, that's fantastic. And if you can get a post-meal blood sugar less than 140, that's ideal, but at least less than 180. You have to be a little bit more vigilant when you're sick because your blood sugars will go up. And if you're on prednisone, your dose of insulin might go up by quadruple. It might go up by at least 4 times. Prednisone really makes insulin not work quite as well, so you need a lot more insulin to do the same job. If you're starting new G-tube feeds or changing your G-tube feeds so you're getting more, you need to be checking in the middle and the end of that G-tube feed to see if you need insulin during it. If you have surgery, they should be checking you in the hospital. If you've been going low, you might need a change in your insulin. Either your insulin is too much, causing you to go low, or you're not getting pre-meal insulin and you're just having reactive hypoglycemia. If you're pregnant, you need to be very vigilant with blood sugar checks. We're very, very, very strict on blood sugar control, and that's for the health of the baby and the mother. So again, if you have CFRD and you ignore it, the prognosis is worse. Worse lung function, worse nutritional status, decreased overall survival, unfortunately. But if you treat it, that can be reversed. So don't be afraid of insulin. You can do insulin. This is definitely something you can handle. It's scary at first, but holy cow, you've lived your life with CF. You've done a good job so far. You can keep doing it, and it really does increase your survival. And you guys should be living to ripe old age now. With our good pulmonary toilet, you should take advantage of what they're offering you. But remember that if you're living with diabetes, you also have to remember that you have diabetes, which is a second disease. So make sure you're having your doctor check you for complications of diabetes. Even though people in the past with CF have not been reported to have a lot of complications from their diabetes. Part of the reason I think people with CF in the past have not been reported to have complications from their diabetes because they weren't checking for complications and because people weren't living as long. And now people are living a lot longer. So if you have a longer lifespan, you have more opportunity to have problems. So make sure you're having your eyes checked and your kidneys checked. Make sure your blood pressure stays in control and your cholesterol stay in control. If you're having problems with weight loss, if you're having problems with fatigue, if you're having problems with more dehydration, more infections, or decreasing lung function, think about tuning up your diabetes. So in the last 5-10 minutes here, I just want to talk to you a little bit about what's up and coming in CFRD. One is ivacaftor and Orkambi. So some or all of you might be on one or the other of these medications. These medications are correctors for your cystic fibrosis, but they may also help your pancreatic function as well. Even people who've had long-standing diabetes who are treated with ivacaftor alone, and that's not even Orkambi, which is the combination drug, had some increase in their own insulin production after they started on the drug. And I've noticed clinically that when people start on Orkambi, about 10 to 12 months later, their insulin requirement, if they have CFRD, has been decreasing. So I'm thinking that once we start to have more studies on these medications, that even though they might not completely reverse diabetes, they may improve the diabetes, make you require less insulin. And I'm hoping that for the children that it will actually prevent development of diabetes altogether. So these are some hopeful things for us. These are some technologies that you can use to help control your diabetes if you want to. So this here is called a continuous glucose monitor. And if you wear this on your body, it has a small, I don't know, maybe 6 millimeter or so filament that's like a hair that's injected into your body and it's stuck there with that sticker. And then this little piece collects blood sugar information every 5 minutes and sends it to a little screen that looks like this so that you can see your blood sugars every 5 minutes throughout the day. And then it tells you, oh, your blood sugar is 128 and going down or whatnot. That actually is really helpful for some people to understand how their blood sugars go up after different things they eat. So it allows them to give appropriate amounts of insulin. For example, like if you have a Scandishake, you might see a big spike afterwards and go, oh, I probably need a unit or two of insulin before I eat that. This here is a pump, and it allows you to administer insulin into a second piece. This is called a set into your body, and it stores insulin right here, and then the insulin comes through and gets dripped into your body. And so instead of having to give an injection at every meal, you can actually just type in your blood sugar and what you're going to eat into the device, and it squirts a little bit of insulin into you. You have to change this piece here every 3 days. So it's still a poke every 3 days, but it's significantly less than multiple daily injection. There's also cordless forms of this, and I would say that probably 80% of my patients with cystic fibrosis related diabetes who require a pump like the cordless type, just because most people feel like they're connected to vests and various different things too much of their life, and they prefer to just be cordless and not have to worry about it. And the cordless device looks similar to this and stores the insulin inside of it, and you can control it with like a remote control. So one thing that I've been using continuous glucose monitoring for is to see if people should get on insulin before they're actually diagnosed with CFRD. Because we know that people's weight and lung function in the year or two before they get diagnosed with CFRD decline. I'm always on the watch for people who qualify for insulin before they experience any weight or lung function decline. So if you put a continuous glucose monitor on people and they have blood sugars higher than 140 for more than 4% of the time they wear it, more than 4% is all. Those people were at higher risk of having declining weight and lung function in the preceding year. So what Dr. Moran is doing is putting everybody who has worn a CGM and has more than 4% of their time higher than 140 on CGM, she's putting all of those people on insulin. And that data is going to be coming out in the next few years as to whether or not that prevented their lung function decline at all. I do that with a large number of my motivated patients here too. I put them on insulin if they're having blood sugars that are peaking up, hoping that that's going to ultimately prolong their good lung functions and prolong their good nutrition. So in the future, we're wondering if we're actually going to be making diagnosis of CFRD on CGM. Or if we'll use OGTT and just combine that with the presence of pulmonary function decline or body mass index decline or linear growth problems or pubertal delay. Some other things that they're looking at is there any oral agent that we can use in lieu of insulin? Right now, they haven't found any that's been quite as good. They have developed a nasal form of insulin, but unfortunately that inhaled form of insulin causes lung damage, so it's not appropriate for people with cystic fibrosis. And then they're looking at earlier use of insulin. And those are all things that are going to be coming up and coming here in the next few years. Those are repeats, yes. So I just wanted to end on an example of a person with cystic fibrosis. This is a boy that I treated in Denver. He's 13, and he had a fasting blood sugar of 94, which is good. And then he took his oral glucose tolerance test, and his 1 hour level went up to 197, so it didn't go out over 200, and his 2 hour level was 152. So he was kind of in that in-between place where they said, oh, you don't have CFRD yet, but maybe your insulin is not working quite as well. His A1C was good. It was 5.4%. And then we put CGM on him, and you can see this is a blood sugar of 60 here, and this is a blood sugar of 200 here, and he had several spikes that went up over 200 and frequent spikes that went over the threshold of 140. He was started on insulin here, and this is his body mass index, and look at how his weight improved. This is incredible. He completely reversed. He was having difficulty keeping on his weight, and he just did phenomenal. So that's why I'm treating with insulin. That's why I think it's important for people to know about CFRD. And now I'm going to have Kat work this so that I can hear you guys in case you have questions.
Okay. Yeah, maybe. Unmute all, or I could just use that.
Oh yeah, do that. That's good.
Except it's. Okay. Well, can you guys hear?
Yeah.
Yeah.
Okay. So
do you guys have any questions about that? Pat has one on her email.
Great. All right. So Jennifer asked about night sweats and whether they're related to CFRD and any way to avoid them. She said that she gets them multiple times throughout the night. She feels like generally changed out bedding, room temperatures, avoiding sugar, but nothing seems to help that. And is that CFRD related?
So Jennifer was wondering if night sweats could be CFRD related. And they could be CFRD related, especially if you are going low. So if you are feeling like you're having night sweats at night, it is a good idea if you can get up and check a blood sugar and see if it's less than 70. If you're on insulin and you're going less than 70, you're probably on too much insulin. If you are on G-tube feeds and you go less than 70 at the end of your G-tube feeds, you actually might not be getting enough insulin during your G-tube feeds, and you might be having that reactive hypoglycemia at the end, and that can cause night sweats as well. On occasion, people will have night sweats from really high blood sugars overnight, and they need more insulin. And they will find that will reverse from that. Some people just have night sweats. And so if none of those things apply to you, then you might just have night sweats. Any other questions?
I have a question. Can you hear me?
Yes.
Okay, so if you're already diagnosed with CF-related diabetes, do you recommend doing like a regular continuous glucose monitoring like once a year?
Yeah, I feel like if you are really good at checking a lot of blood sugars, particularly if you check a fasting blood sugar and then you check 1 hour after eating big meals and after any kind of shakes that you take, if you check in the middle of G-tube feeds if you're on those, you can probably get away without doing CGM once a year. If you are so on your blood sugar checks, or if there's anything that doesn't really seem to be quite adding up, I definitely recommend wearing a CGM once a year because it gives you a ton of information about what's happening. And some people just want a CGM of their own, and if your insurance pays for it, you can always order one of those. It's pricey, like $6,000 out of pocket, so I would not recommend doing it out of pocket. But some people really find a lot of benefit of getting one on their own and just wearing it. You can wear it all the time, but some people will just choose to wear it, once every couple of months and just see that they're on track.
Mm-hmm. Okay. Thank you.
Yeah. Any other?
Sorry.
I have one too. I get you. Anybody else with questions? Brian's talking, but he's muted, so hang on a second.
Are you guys able to hear me? I had a question or comment.
There you are. Yeah.
So I'm one of those examples you were talking about where I've been every clinic visit I go to, they tell me, oh, you're borderline CFRD, you're not quite there yet, and I've never been placed on insulin. I'm inpatient this week or this last couple of weeks, and I just, at my appointment, she finally said, I think we're going to finally, consider that you are CFRD. So they started me on Lantus while I've been inpatient as a small dose. The what you were saying was the long-term one, where it's once a dose in the morning, and that's it. And they started me at two doses or two grams. I forget what the actual measurement is.
Units, yeah.
Units, yeah. Sorry. And so I've been taking that now for 8 days, and my blood sugars seem to have evened out quite a bit throughout the week. I still have had two that were like in the 250s this week, and they were typically at that 1 to 2 hours after a meal or a scan to shake, because we have the scan to shakes here in the hospital, of course. And I guess my question is, and maybe it's too early for me to know, but the idea was to start that and monitor it for the next month or two to see what effect that'll have on me. But when you brought up the night sweats, I get that every night as well. And we had always wondered if that was blood sugar related, and I always got a different answer. Yes, it is. No, it's not. No, it means you have an infection. You're about to have an exacerbation, and that's why you're getting night sweats. So I never really knew if that was part of the insulin or part of the blood sugars, which I think I'm going to start learning a lot more about it. And I think in all reality that, we probably should have started it a few years ago for me, it would be my guess.
Yeah, and you might think about, I usually try not to push the dose too much when you're sick, because you usually need different doses when you're sick than when you're healthy. But one thing that you can do is if you get night sweats in the hospital, have them check a blood sugar and just see what you are.
And they have, when you're having, they've been coming in at 2 in the morning, 2:30 in the morning. Yeah. And nice. I've typically been like at the 130 to 100 range around that time.
And then the other thing that I would do is, if I was your doctor, I'd push the dose of Lantus until your morning blood sugar, your fasting blood sugar, was 70 to 100. So if you're not in that range, you might need a little bit more, because that'll keep pushing you down. And usually in a guy your size, you can probably, even if you're pretty early on, most people your size can handle about 4 to 8 units. So you might be able to take a little bit more. And then some people, even when they get there, they still have those spikes after those high carb things or scan to shakes. And so some people benefit from just a 1 to 2 unit dose of short acting just for those specific times. So just when you're taking a scan to shake, or just when you have like 1,000 French fries, or, like where you really just go crazy with something. But I think, being in the hospital, it's sometimes a little bit harder to figure out because you're dealing with illness too. So you don't want to go home on something too aggressive for when you're healthy. But it sounds like they're working with you, and yeah. I mean, and I don't think that there's any shame in you just saying, it doesn't seem like I'm tight enough. You want to crank me up? Because you're in the hospital. If it's too much, you'll know.
Yeah. And those morning reads that you were talking about, mine have been in the 100 to 112 range for the last 4 mornings.
Oh, yeah, I'd crank you up. Double it.
Boost it up.
Yeah.
No, I think that was a really cool, little seminar, because it's something that's always been talked to about it, but never addressed with me. And now it is finally. So I'm trying to learn as much as I can about it to try to, stop any further progression of getting worse, I guess.
Yeah, it sounds timely for you.
Yeah.
Yeah. Anything else from you guys? Well, thank you. I appreciate having you, having me come talk to you guys. That was great.
Appreciate it.
Yeah. Thank you.
Thanks, guys.
Thank you.
Such a long delay.
Y'all take it easy.
See you later.
Bye.